Okay. A very good evening and welcome everyone. Thank you for joining us today to our today's COP webinar. Today we are presenting Strengthening Primary Healthcare Using Digital Solutions. Now I would like to introduce Professor Vikram Datta. Professor Vikram Datta is the Director Professor at Department of Neonatology, Lady Hardinge Medical College, New Delhi. He is the President of Nationwide Quality of Care Network and Vice President of National Neonatology Forum, India. He is also a guest editor at BMJ Open Quality South Asia Edition. He is a member of editorial board at International Journal for Quality in Healthcare Communications. He is expert at the International Society for Quality in Healthcare. He is lead at National Mentoring Group and Technical Resource Group and lead at Sustainable Model for Lakshya by Ministry of Health and Family Welfare, India. He is a member of Quality Equity Dignity Working Group by Ministry of Health and Family Welfare, India. I welcome you, sir, and I request you to formally invite our today's speaker, Dr. Rajesh Khanna.
Thank you so much, Dr. Komal. Good evening, friends. I think what a wonderful opportunity to connect with friends from the Wish Foundation, led by none other than the most able Dr. Rajesh Khanna. Dr. Rajesh Khanna has been a friend for decades now, and I think in his current capacity, he needs no introduction to the group which is here. But for the sake of multiple members who are present in this webinar today, I think close to 100 people who are attending this webinar, and the number continues to increase. I take this opportunity to welcome friends from the neighboring countries, Bhutan and Maldives as well as Bangladesh, who have joined this session to hear the experience of Dr. Rajesh Khanna and the team from WISH and LEHS. Dr. Khanna is a Senior Director Programs at LEHS WISH India. Dr. Khanna has more than 25 years of experience as a clinician, team leader, program manager, researcher, technical expert, policymaker, and advocate for healthcare solutions in the field of maternal, newborn, child health, and adolescent health, along with nutrition and health system strengthening. He has had a rich experience of working with different institutions like a missionary hospital, a health policy making unit in the United Kingdom, a government-supported resource center in India, and a global child rights-based civil society organization. Dr. Khanna has served as a technical expert at the international level and has worked with multiple organizations like the NICE UK, WHO Geneva headquarters, WHO CRO, and the Global Technical Leadership Group of Save the Children. He has a keen interest in bridging the gap between research policy and programs for developing healthcare solutions for the most vulnerable populations by adopting a people-centered approach. And what we have not mentioned here is that Dr. Khanna is a pediatrician by training. And over to you, Dr. Khanna. We look forward to a very informative and enlightening session with you and your team from the Wish Foundation. The floor is all yours, sir.
Okay. Thank you. Thank you so much, Dr. Datta, Dr. Komal, and the entire NQCN team. First of all, good morning, good afternoon, good evening, wherever you are joining. Thank you so much, first of all, to the NQCN team for inviting us out here. When I was looking into the video, it was quite a nostalgic movement because, as Professor Datta said, that I'm a pediatrician. So it's good to see that the NQCN journey started from neonatology and something which was very close to is still close to my heart. But today, the topic that I'm going to share with all of you is slightly different from the way things are, NQCN has been focusing on. And probably at the end of the day, end of the presentation, I'm sure you'll all agree, and I hope NQCN also starts looking into the way forward and working on primary healthcare with us. I'll just share the screen. Just give me a minute. Okay. Sorry. Yeah. So what I'm going to speak about is primary healthcare in India. The outline will be, I'll first speak about, tell you a little bit about the evolution and milestones in India, the new policy of Ayushman Bharat, which is supposed to be a game changer in our quest to achieve the universal health coverage. What are the current challenges that we see? Something about my organization, which is one of those rare organizations which right from the beginning had focused on changing bringing about a paradigm shift in how do we strengthen the primary health system. And within the primary health system, there are different models, but I will touch upon a model on digital health and wellness center where we are trying to integrate digital solutions. So it's journey, how are we ensuring the quality, and then the learnings and the way forward. Now, if you look into primary healthcare, of course, it's quite a wordy and I don't expect everyone to go through it, but I'll go through the years. Now, before India gained independence, Professor Bohor, one of the most learned men, thought that if India has to change, if we have to look for improved health and well-being of the population, then it has to be through introducing the concept of primary healthcare. What is primary healthcare? Primary healthcare is actually a whole nation concept, which is now the latest definition that WHO says, where you are trying to achieve the highest possible level of health and well-being of the entire population. And it's focusing on people's need through the entire continuum. And when I say the continuum of care, it's both across the life cycle and around the health systems. And it includes the component of not only preventive, supportive, curative, but also rehabilitative and palliative care. After 46, India gained independence, we continued with the systems, but primary health never gained importance. It was only when 1978 MNCAH came, further focus was given. But still from 1978 to 2005, when NRHM came, the journey was, I would not say it was quite a revolutionary or an exciting, because it was always a confusion between whether we want to go for a vertical health system or a horizontal system strengthening system. After NRHM, a huge focus came, but it was again limited to your MCH services, but a big focus on decentralizing, introducing frontline health workers, making sure community interfaces are there. Then in 2000, but it was entirely rural focus. Then in 2013 was the urban health mission came, and both of them joined together, and we had the national health mission. But again, during that time, the entire focus of the country was on RMNCHA. Of course, we made an evolution from MCH to RMNCH. But then the thought of comprehensive, introducing other elements, came only when the 2017 National Health Policy came. It brought a paradigm shift in the way we looked into the health, moved from selective to comprehensive, free assured services, and under it was the Ayushman Bharat in 2018 that came up. I'll come to Ayushman Bharat a little bit. Now, in between, globally also, the world recognized that until primary health care gets strengthened, we will not achieve the goals of universal health coverage and SDG 3 specifically. Following 2018 was also the digital health mission that came up. Now, what is Ayushman Bharat? What was the paradigm shift that Ayushman Bharat brought up? Now, the national health policy focused on universality, equity, patient-centered care. So there were 4 components, but I'm going to focus more on the 2 components. The first component relates to, we have the primary health centers, the sub-centers. The idea was that can we convert them into health and wellness centers? Now, when you say wellness centers, it is an evolution from illness to wellness. Initially, the entire focus had been on RMNCHA services and on illness. But we also realized as a country that the NCDs is a growing thing. There are emergencies to be taken care of. Geriatric care is there, ophthalmology, ENT, mental illnesses has been raised, and nothing more than COVID has shown us. So unless we have a mechanism to take care of all these in a holistic and comprehensive manner. So the idea shifted from creation of just simple sub-centers and primary healthcare centers to comprehensive, to these facilities which can provide comprehensive package of 12 services as mandated under Ayushman Bharat. Now this was at the primary level, and at the secondary level was the PMJY or the Jan Arogya Yojana, which provided incentives and insurance coverage to the 40% of the population, which in India is more than 500 million population. Now, all these things came up, and apart from it was also the digital health mission, which has recently come. And there's another ABHIM, which is the health infrastructure mission, which is also part of this, but I'm not going into the depth of it. But if you look into it, it's since independence and more, even if I take it from the Alma Ata, 1978, what is the healthcare system in our country? We are still struggling with providing access, human resources, drugs, diagnostics, preventive promotive medicines, and coupled with this is the growing emergence of NCDs in the country. Similarly, digitization. Yes, recently there has been a huge push towards getting a digital infrastructure ready. And I'm sure this will give us excellent benefits in the time to come. But still, there are a lot of challenges in terms of infrastructure, connectivity, supply chain management, digitization of data. So this is the scenario that I'm presenting, because when we started, this scenario was not very different. Of course, it's rapidly changing.
And affordable. A wish that we strive to fulfill every day. Since 2015, WISH has been on a mission to transform primary healthcare through innovations, demonstrating scalable and replicable models as an effort towards building resilient healthcare systems. In partnership with state government, with access to proper healthcare. For a country like India, this underscores the need for a robust primary healthcare system that is both accessible and affordable. A wish that we strive to fulfill every day. Since 2015, WISH has been on a mission to transform primary healthcare through innovations, demonstrating scalable and replicable models as an effort towards building resilient healthcare systems. In partnership with state governments, international agencies, and the private sector, WISH today manages and monitors 650 plus digital primary healthcare facilities across Central, North, and East India, serving a population of approximately 140 million. Moreover, we are continually increasing access to basic healthcare services by expanding our network of clinics and by enhancing the quality of services with the help of unique BOCTs like mobile labs, tele-ECG, and blood monitoring system, among several others, that reduce the impact on out-of-pocket expenditures. This approach is paying dividends, especially during the ongoing pandemic, as our primary health clinics are playing an integral role in the COVID-19 response across all the 5 states. Having screened 5.57 million people so far, 0.59 million people with influenza-like illness symptoms were diagnosed and action taken as per the guidelines of the Government of India. In addition, we are partnering with governments in the training and capacity building of healthcare personnel, in establishing control rooms to support oversight of quarantine efforts, distributing PPE kits, and sensitizing communities on proper hygiene and social distancing practices. In the past 5 years, through our direct implementation as well as techno-managerial support to state, WISH has reached 21.2 million beneficiaries. This is a significant leap towards our wish for a healthy India at 80, our goal to reach 100 million citizens by the year 2027. As ambitious as it may seem, we believe that all this and more can be achieved with a continued commitment to collaboration, public and private investment, and by leveraging innovation. We thank all our partners for joining us in our journey. Our vision of a healthier India by 2027 and beyond can indeed become a reality through our collaborative efforts.
Yeah, so this was a small glimpse of what the organization stands for. However, being a video, this is 2 years old. Our current footprint, we are working in across 5 states, have more than 300 staff, running more than 1,000 clinics, either directly or mainly now over the last 3 years, we have shifted to providing technical advisory support to the states and touched more than 140 million lives. Apart from it, we are also working at the national level and through the National Health Innovation Unit, where the main idea is wherever digital innovations are there, can we get them integrated into the systems? No, though we have been working, there are 3 different models where we are predominantly, we have gained our experience. And it is primarily based on the principles of primary healthcare. How do you improve access, acceptability, affordability, and availability of services? One is where we are transforming rural and the urban primary healthcare models, working together with the governments, and that includes especially the difficult areas. Most of them are aspirational districts and also the tea gardens. Then there are digital urban health clinics. You would have heard, many of you, about the Mohalla clinics in Delhi and the Sanjeevani clinics in MP, and the Digital Health and Wellness Center initiative, which is a tech-enabled health and wellness center, which I'll be discussing today. Now, in all the 3 areas of work, digital health plays an important role. And our role has been based, and our experience has helped us to gain through the knowledge, being the knowledge management and the technical support partner. Now, what is Digital Health and Wellness Center? Now, predominantly, we looked into what are the major constraints of primary healthcare. And that is what we are trying to look into. Can we provide digital solutions to these problems which we have been struggling to take care of over the past 40, 60 years? The availability of the doctors. We have the teleconsultations. The point of care devices for diagnostics. Of course, there are a certain level of diagnostics available at every level, but it is about their availability. So can this be provided at the lowest level of facility in terms of health and wellness centers or the sub-centers and the primary health centers? Drugs, which are the main reason for out-of-pocket expenditure of the poor. 70% of our out-of-pocket expenditure in our country is because of the limited access of quality drugs. Can we have medicine vending machines? And underlying them is the major 4 factors where we realize that would really help us to improve and enable the system to move. Electronic health record and data analytics, which would help us in real-time monitoring. E-prescriptions, the learning management system, which really got a boost during COVID, because you could ensure training and capacity building of the healthcare workers sitting remotely in the offices. And wherever you're looking into use of technology and digital devices, it's very important to have an uninterrupted supply of power. In that scenarios, can we look into providing cleaner sources of fuel, cleaner, uninterrupted, which would provide uninterrupted energy, and that is through solar panels. Now, these are the 3 main things of doctors, diagnostics, and drugs, and you can see the different devices that we are using. Now, CliniBay is an instrument which helps us in not only teleconsultation, but also helps in vitals monitoring. Diagnostics, there are different diagnostics. We have used close to, I think, 12 to 15 diagnostics, and this has been through an association with BIRAC, where they have an MOU with us, where they had asked us to, can you test those in the field level and give a feedback to the social entrepreneurs who were coming out with these devices. So just labeled it. TriCog is a mobile ECG machine, and INA is a station which helps in comprehensive provision of 6 parameters, which include hemoglobin, lipid profile, HbA1c, which is used for diabetes and for blood monitoring of diabetic patients and to identify the risk, and then an automatic vending machine. And this is a photograph that you can see of a digital health and wellness centers where an EHR is being taken. The patient is sitting in front of a teleconsultation. This is before Clinibay was a Cliniport, and this is an older machine. And then on the left side is your medicine vending machine. Now, what is the patient's journey? How does it go? When a patient visits, he gets registered and the vitals are monitored. Depending on whether the patient requires an audiovisual consultation, then he is taken. If it requires a medical consultation, a medical officer consultation takes place. If the medical consultation feels that the patient requires a specialist consultation, then only he is referred for a specialist consultation. Otherwise, you can see 3 pathways post-consultation. The doctor prescribes medicine, e-prescription is generated automatically. The medicine vending machine, using the barcode that is there in the e-prescription, dispenses the medicine. Secondly, if there is a need of any diagnostics, if it's a point of care devices can take care of it, it's done. If it's not there, then the patient needs to be referred for advanced diagnostics. Or if the medical officer feels that the patient needs a specialist consultation, then it is done through specialist and he is referred to a higher facility. Now, interestingly, what has happened is a patient who is coming to a remote place in one of an aspirational districts is able to access doctor, specialist consultation, drugs, and diagnostics from a single place. Now, this journey started, our journey of starting this digital health and wellness initiative started way back in March 2017, and it was the first PHC where we worked was in Rajasthan. This model was showcased at National Innovation Summit 2017, and it also received the Best Startup in Healthcare Award in 2019. So starting from there, we have now about 100 facilities spread across the 4 states, with Rajasthan having 45, Uttar Pradesh and Madhya Pradesh having 20, and Assam 50. And friends, all these facilities are in among the aspirational districts or the most marginalized areas. Now, when we started our journey, it was also important to do, the facilities that we are working, how well prepared they are. Are they able to provide the services? You all must be aware of the SARA framework, which has been developed by WHO, that is the service availability and the readiness assessment. We use the same framework and did an assessment of the 100 facilities across all the 12 domains, themes, which have been prescribed under Ayushman Bharat. I'm just showing you for the NCDs. Now, if you look into the sub-centers in Uttar Pradesh, you can see that even though the services are available, which is not very good score if you see, in the spidergram on the left side is 40, 30, so somewhere hovering about 40. But their service, the readiness of the facility, and readiness when I mean is across the health system blocks, that is infrastructure, human resource, capacity of them, drugs, diagnostics, IT systems, so everything is there. And on the right side, you can see diagnostics, 0 across all of them. Drugs and IT readiness was minimalistic. So this was the time when Ayushman Bharat came and we started our journey. Now the system, the situation was not very different from in Rajasthan. It's the same thing with 3 diagnostic drugs and IT readiness. Now through this, we have gone through a journey. But interestingly, what I'll tell you is the journey over the past 2 years, what we have done. And there are certain mechanisms, because it's a community of practice for quality improvement. I'll just be focusing on 4 components Two of them are which we are doing it on an everyday basis, the monitoring mechanisms, and 3 and 4, the prescription audits and the patient satisfaction score, which has been done, evaluated externally by a third party. Now, if you look into the trend of teleconsultations, because teleconsultation is the main mechanism for all the digital solutions that we are working in. When we started teleconsultations, the acceptance was not very good. However, of course, some things have helped with COVID, but what we are seeing is that patients are gradually accepting. So out of the total consultations, you are seeing about 30% now, since the start of this year, are the teleconsultations that are happening. And out of those 30%, 65%, 2/3 are general, and 1/3 are the specialist consultations. Gynecology, maternal child health, so pediatrician and gynecologist, 60% specialist consultations. But good to see that dermatology, orthopedics are also coming up now. What we are also seeing is that teleconsultations, when we are working to use any digital mechanism, our approach as an organization is, are we making dent? Is it reaching to the most needy, marginalized population? And among those, you all would understand that when we talk of equity, age, gender, geography, education status, these are the 4 to 6 criteria that WHO always talks about. So what we saw is that females are accessing more. And similarly, equal distribution, not an equal distribution, but I would say all age groups are being reached. Interestingly, your geriatric population, 50 plus, I have done it at this point, it's 50 plus, but 60 plus is approximately 18% population we are reaching. So quite a big chunk of this is there. We have a referral rate of 4%, where the teleconsultations, after teleconsultation, the patients were referred. In those scenarios, the face-to-face consultation was the main reason that the patient had to be referred for a face-to-face. And you can understand if you look into the pie diagram below by the types of specialists, most of the females who require physical examination by a gynecologist had to be referred. Similarly, orthopedics, pediatrics, and dermatologists. So sometimes it becomes a little bit challenging to do these teleconsultations. So these are there, but a huge chunk of other patients could be taken care of at the level of these health and wellness centers. Now, coming to the second component, this is operational issues we started monitoring over the past 1.5 years. And what we realized was that a major chunk of these operational issues were related to hardware, internet, and software issues. Now, interestingly, we have been able to resolve 89%. And I'll be very honest that probably it does not include all the issues that have come, but a major chunk of this we have been able to record. Now, when we look into internet issues, I will just bring about a very interesting thing that when we started, so at some places, what was there was that there were broadband providers were there, but we were not getting the services. So that was easy that we made sure that the cables were extended and we connected with the broadband provider and that. But somewhere things were not happening at all. So in those cases, we used RFDs, the radio frequency devices or the dongles that were provided. So that helped. The hardware problems was particularly unique, and that required a lot of operational cost at that point of time. Because when you start certain things, it always requires a little bit of more push. But however, happy to share with you that over the past 6 months, things seem to have really smoothened up. If you look into the waiting time for teleconsultation and an average time taken for each consultation, now this is something that we relied is going to be a very important parameter for quality. So we started monitoring it. And what we relied is that 45% were less than 1 minute. So probably it could also be because we were not bringing everyone who's coming for consultation for a teleconsultation. That was there. But interestingly, when you look into the average time taken for each consultation, it was about 1 to 5 minute, it means that a medical officer or a specialist was spending this much time for consultation. In addition to following this, what we also did was an third-party evaluation of about 1,000 prescriptions, e-prescriptions, and compared them to the manual prescriptions at that time. And there are certain reference values given by WHO to ensure whether the prescription is appropriate and it is complete. Now, when you say complete, it is whether the patient's name is there, demographic details are there, symptoms, diagnosis, medicines, duration, follow-up, what we normally see in a prescription from, probably I would say, from medical colleges. And on the other side is your appropriateness, where the WHO had given certain criteria. Now, when we did, we realized that 77% of the e-prescription were completed and 83% were appropriate. And when we compared them with the manual prescriptions, our e-prescriptions had very good results. They compared much better as compared to the manual prescription. And I think interestingly will be your encounters with an antibiotics and drugs and encounters with the injections prescribed. Another evaluation that was done was a satisfaction survey of 425 patients, and it was done using a 5-point Likert scale, and only 4 and 5 scores were taken as the patient was satisfied. And here also about 92% patients we found them to be satisfied. What were the factors? And the question was that would they revisit it? And out of that, if you look into the factors which scored the highest, so access, if the service is available closer to the community, which is one of the prime factor to ensure primary health care, that stood up. Nothing to do with our digital solutions, but it is about making sure access is available. But it's also about the availability of doctors, drugs, staff behavior, and the time friendliness. Here, I would like to bring one important point that many times when I said operational challenges, and then there was internet was not working, and that times the patients, it was very difficult to keep the patients waiting. So those patients usually left the facility. So friends, it has been quite an exciting journey for us over the past 5 years, I would say, but more over the past 3 years. And what we realize is that digital health, first of all, has a huge potential to improve access, availability, and quality. We have seen its potential to solve the complex health system issues that we have been facing for such a long time. And I think at this point of time, we are very excited because there's a National Digital Health Mission out there, which has laid out the framework. So we know that the country is moving in the right, and so our path is quite synchronous with what the government is looking forward to. The second is whenever we are trying to bring any innovative PHC model, you have to be very dynamic and flexible in approach. When we started, we realized that the population and first of all, the population did not feel comfortable with teleconsultations, and the doctor's acceptance was quite a big challenge. However, over a period of time, that has improved a lot, and that was seen in the percentage proportion of teleconsultations we are having. The second is your operational challenges and cost, and we have to be very careful of whether we want to continue with certain digital solutions, knowing that it is evolving rapidly. Now, just to share with you that, like the medicine vending machine, we are realizing that it requires high maintenance and cost. So we are in the process of phasing it out and moving to manual distribution of medicines by the healthcare worker. Maybe in the future, we will have to look into certain hybrid models also, and that we are already exploring. Another important aspect is that the quality parameters and processes have to start from the beginning. We thought of real-time analytics, quality, standardization of data, electronic health records, all has been thought of. But as we are evolving, we are also realizing that that is very important to have certain parameters for teleconsultations, POCDs. And last but not the least, it's very important to harness the potential of private sector and social entrepreneurs. These are the people who are bringing digital technology, and how do we use their expertise and their technology for the benefit of the larger population is something that we are trying our best. Moving forward, under the National Digital Health Mission, the country has already brought a very ambitious plan to integrate all the solutions, to make a framework where all the digital solutions can be integrated. There's a sandbox that has been created, and all the digital solutions which have a potential, they are passed through that sandbox. We have eSanjeevani from the government, the ABHA, which is an EHR and EMR recording, e-pharmacies we brought about. Similarly, we are also looking into ways of how these mechanisms and our solutions can be integrated into the NDHM framework. Second, it's high time that we look into establishing quality parameters and indicators for digital health. And here, I think none better than NQCN to take a lead in it. The third is, as we are rapidly moving into introducing digital health into the health systems, it's important to build the capacity of the health workers. Of course, systemic changes are required, but health workers who are going to be the backbone of our primary healthcare system, and especially when we talk of it's about moving into a hybrid model, we need to build their capacity on how do we use the digital health tools. Like to thank everyone, the state governments, community partners, and especially acknowledge the donors who have been very supportive of us and all the partners. Thank you. I will end with this, but I would also like to introduce the panel who is there. I have with me, first of all, like to acknowledge the leadership of the CEO of WISH, Mr. Rajesh Ranjan Singh. Also, we have the technical lead, Dr. Anupa, operational lead, Mr. Dinesh, and the monitoring evaluation lead, Mr. Satyaban with us, and we'll be happy to answer any questions that you have.
Thank you so much, Dr. Rajesh. I think that was really an excellent presentation and very informative and an eye-opener for most of us, and quite futuristic as well. And I think over the coming decades, this is going to be the mainstream in driving primary healthcare to the next levels across the country. So we will start with a set of questions very quickly for you and your team. I welcome Dr. Anupa, Satyaban, and the Rajesh Ranjan and Mr. Dinesh from the team. And the questions, I will just start asking the questions in no particular order. We have a question from Dr. Ajit Sutke. Dr. Ajit mentions he wants to compliment you, and I would request Ajit to unmute himself and to ask the question directly. So Ajit, we will just unmute you. Komal, can you just unmute Ajit, and Ajit can ask his question directly?
Sure, sir.
Yeah, thanks. Thank you. So yeah, first of all, great presentation, Raj. Sorry, I was actually late in joining, so probably I missed some earlier part of your presentation, which I'm sure when the video is shared by Dr. Vikram, I'll be able to watch it. One thing was which I wanted to understand is, has WISH developed its own teleconsultation platform, or are you using the one which CDAC has already developed, the eSanjeevani platform? And the follow-up question is that how many clinics is WISH supporting in Indore? As we had discussed earlier, Rajesh, that We are working in Indore in Madhya Pradesh, and under innovations also, we are trying to do something very interesting in integrated doorstep delivery of healthcare services as a pilot. So from that perspective, I was just thinking and wanted to understand.
Okay, thank you, Ajit. First of all, we are working on our own. This is a teleconsultation portal that was developed by us only at that time because eSanjeevani had not been rolled out. Okay, so when we started our journey, that is there, and you're absolutely right. As we move along, the idea is how do we integrate it with the and under the NDHM framework, how do we integrate? Secondly, in Indore, we'll be more than happy to explore with you what is it we are already, so the Sanjeevani clinics are already working in urban. So I don't have the exact number, but I'm sure it's going to be approximately 10 or more, which I've already. But you will be glad to know that recently Sanjeevani clinics, the government of MP is scaling from 110 to 600 using the new 15th Finance Commission. So already the plan is there. I will have to check with the MP team how many are part of the Indore city.
Thanks, Rajesh.
Thank you so much, Ajit, for that question. Next, we have Dr. Kedar Sableshwarkar from Aurangabad. Dr. Kedar, can you just unmute yourself and ask your question? Dr. Komal, can you unmute Dr. Kedar, please?
Done, sir.
Yeah. Hello. Yeah. Am I audible?
Yeah, you're audible. Please go ahead, Kedar.
Excellent talk, Dr. Rajesh. Thank you for that. I just wanted to know any change, especially shifting from, say, paper to digital. There are a lot of cultural challenges which we encounter. As we tried in our NICU to become paperless, we had a lot of resistance from doctors and nurses. And one day I had to take a decision that from tomorrow onward, there won't be a paper available. So from then on, now 3 years, we are paperless. So how do you, what is your experience regarding these behavioral challenges and how do you address them? Thank you.
Dr. Anupa, would you like to take a stab at this? You are muted.
So, thank you so much for your question. There are two parts to your question. First of all, if you would remember, there was one slide which was shared by Dr. Khanna, which was talking about how steadily the teleconsultation numbers have gone up, though some push has been because of COVID. But the acceptability somewhere can be judged, whether COVID or whatever the precipitating causes were, the acceptability within the community has increased. And especially you can see it, even at the aspirational districts where our digital health and wellness centers are at the level of sub-centers. So that is some data which is saying that, somewhere the acceptability has increased. And moving forward, as we as an organization are thinking about incorporating quality, we also understand that quality will need to leverage cultural changes, whether in terms of healthcare providers or whether in terms of community for accepting anything which is new, in this case, digital solutions. So moving forward, we have decided that we will be taking the QI approach to it, where community will play an important role, and we will try to address it through quality improvement methodology, the culture. Whether we take up projects as of now as a thought with the digital processes of care, or whether the processes of care involved in delivering comprehensive primary health care. So I hope that answers your question.
Oh, thank you. One more question. Are you using any assessment scale for understanding the impact of your trainings?
So as of now, trainings, we have developed a tool, and we have incorporated the Kirkpatrick model in our training, not so much the step 3 and 4. Just now we have come up with a framework for assessing our trainings, which does involve the Kirkpatrick step 1 and step 2. And we will be happy moving on to be sharing those results with all of you in future.
Yeah, thank you. We'll be eagerly waiting for your experience. Thank you.
Thank you so much, Kedar and Dr. Anupa, for those answers. And I next move to Dr. Amol Joshi. Dr. Amol Joshi is a faculty at Aurangabad Medical College and a founding member of NQCN. Amol, please go ahead.
Good evening. Thank you for the excellent presentation. And I was really surprised to see that the things are being already implemented at PHC level with so much of digitization already happening. My question is regarding we are always having shortage of manpower. And it is not very easy to even get the manpower for the PHCs and in adequate numbers. So I had come across with some app facility-based MNCAH which was launched, and ASHA workers used to actually do it, or even a person who can read or write or who can handle a mobile can just click and say whether there is a danger sign or no. So that if it is OPD, majority of the OPD illnesses can be taken care by self-care or can be taken care at home itself. So my question is, are we looking forward to such self-care sort of activity in future so that the manpower crunch can be curtailed, number one? And the second question is, with all these things, we are not yet using alternative medicines. So many alternative pathies are available. Naturopathy, maybe Ayurveda, maybe homeopathy. What is your stand, or what is the next future or policy of government regarding this? Thank you.
Okay. First of all, thank you, Dr. Amol, for asking. To answer your first question regarding movement from, first of all, where we are working are not primary health centers. We are working even lower than that. It's about sub-centers. So all the photographs that you are seeing, these are all manned by your GNMs, and now we have the community health officers, the CHOs. So you'll be surprised to know that we are working even at a much lower level. Secondly, coming to your, yes, definitely home-based care, or the self-centered care for mobile, FMNCs, that is going to be the thought. We are even planning to move one step ahead. Can certain services be delivered at home? And patient, do we require the patient to come to facility for every small illness? That is something that the organization is at present thinking about. Okay, so definitely there is a mechanism to this. The third part is related to your comprehensive and alternative medicines. If it's part of the comprehensive primary healthcare, where yoga is definitely there, so that's definitely we are also taking about. But that can be yoga. At this point of time, we are supporting as I told you, that we are also supporting the state government in rolling out the health and wellness centers and establishing them. So in some of the states, even the yoga modules and all that have been developed by our teams, and we are rolling it out. So very much in sync with what the government wants under Ayushman Bharat.
Yes, thank you so much. Thank you for the answers. Thank you.
I think that answers your question, Amol. So there's been a question, Dr. Khanna, from Rajesh, but I think you have answered it. He has a question. In fact, he says that it is regarding the machine, medicine vending machine. He says that's a great idea, but don't you think that this will increase the irrational use of medicines and loss of employment for pharmacy graduates? So I think you just mentioned that you are trying to shift to a manual mode now because the cost of putting up the machine is quite costly. But what about the irrational use? Do you have an answer to that? In fact, I think that the e-prescriptions had a 2, less than 2, and the manual ones had much higher. So your inputs on that, Dr.
I know, absolutely spot on, Dr. Mehta. Sir, that this was something that we also realized, and especially now with e-prescription, I think you cannot give for more than 3 days, if I'm not wrong. So in that scenario, the dispensation, the medicines used to dispense 10, a blister of 10 medicines at one time. So that's why we said operational cost was increasing a lot. And of course, to ensure irrational, to prevent irrational use of medicines and all. That's the decision we have taken, is that we are thinking of phasing it out now.
So I think that answers the question. There's another question from a participant who's not mentioned his or her name. And the question is, can you please elaborate the criteria that was used while selecting the primary health centers? I know it's not primary health centers, sub-centers a bit more. How did it work in hard to reach areas or in urban areas? So what are the selection criteria and any experience in hard to reach areas?
I have my colleague Dinesh, who has been part of the team, Dinesh and Satya, who has been guided. So Dinesh and Satya, would you like to take this question?
Yes, sir. So when we have started on exploring the primary healthcare model, at that time, the selection of the subcenter for health and wellness center was a very challenging. So we have taken few criteria. One was the population, where the population is high. The second was the distance from the PHC. So let's say our distance, minimum distance from the PHC should be 5 or more. The population should be more than 2,500 or more. We have also gone through the internet connectivity, because with the telemedicine you require dedicated internet. So we have a feasibility of the internet. So there are a few more criteria we have taken, and based on those criteria we have selected the subcenters. So we have subcenters SWC at the areas where like Kumbhalgarh, if you know, or in Rajsamand, which is a tribal zone. So we have tried in hard to reach, tribal, and all areas.
So I think, is there anything else to add, Dr. Khanna, to what he just mentioned?
No, I think what we saw, as you rightly said, Professor Datta, that it is quite futuristic at this point of time. But the thing was that somebody had to take this challenge of trying something to show things can be done. I'll be very honest that over this journey, it has shown us a lot of things. It helped us gain a lot of experience on teleconsultations. What are the parameters that need to be developed for it? You know, the EHR process. You know, a lot of things related to supply chain management, which we are now working, and now we are working on developing a digital integrated health management system. So all these things is helping us to think that for the primary healthcare, what are the real operational challenges? I know the time was short, so we could end, and probably my friends out here, Dinesh, Satya, and Anupa, they are much more experienced in this. But what I can clearly see that there is a huge potential to tackle the lot of chronic challenges that we have been feeling, I would say. And unless we make a change in the way we tackle these solutions, these problems, we are going to again come after 5 years, think about it, are we on the right track or not? But unless we try it, we will not be able to say. But I think fortunately, this is an excellent time to try these things and to bring about a lot of change in the way primary healthcare. And primary healthcare needs to be emphasized again and again, because that is where your entire health structure and health system of the country is dependent on.
I think Dr. Anupa, thank you so much, Dr. Khanna. Dr. Anupa, you want to add something quickly?
I just want to bring out one very important factor, which has been, the strength of WISH. And that is that we started out in 2017 with teleconsultations and digital solutions, whereas eSanjeevani and our counterparts came out much later. So that has a proven track record that, these kind of solutions have been able to, make inroads in those areas and have actually been able to sustain. We have been able to sustain them for past 5 years, which I think is a very important thing to be highlighted here.
So I think I would just put the last question. We have some more questions, but I'm sorry. And there's a question which is from an anonymous participant just mentions that will we get access to this PPTs? Yes, definitely. You can visit the Communities of Practice YouTube channel, and all the videos now are reposited there, free to access by everybody, including all the past 2 years videos of this Communities of Practice, and also the future videos which would be coming up. So within the next couple of days, you'll get access to full video with minor editings. And my last question, Dr. Khanna, and to the team is, have you in this short journey of using this innovative solution at sub-center level come across some ethical dilemmas in delivering, this innovative digital solution? And if yes, what were they, and how did the team offset that? And were there any legalities also involved with it?
Dinesh, would you like to take this share? Dinesh and Satya? Then we can add.
Sure. So initially, why we have come with a vending machine, because dispensing medicine without pharmacy was a broader challenge. So we had a good discussion with various state governments, particularly in Rajasthan, and we have come out with the ideas. If, like in airport, we have a dispensing of the Pepsi and Cola, why not the medicine? So we found that this is a doable, and at that point of time, the ministry and the directorate was excited. Let's try this, whether at a distance things the pharmacist may not be available. So this experiment has helped us to understand how we can reduce the HR shortages. However, there was again the question raised on the dispensing, particularly. So the medicines, what were the message dispensed in the a packet. So let's say we require only 9 medicines or 6 medicines, though they dispense 10. So we face this type of challenges, and gradually we found a solution as well. But there are issues, and accordingly we have, with the support of the government, we have come out with a solution.
So I think it would be interesting to know about the ethical challenges as we move ahead, and also replacing the human resources with the point of care devices. I think the validity and the accuracy and the various others, like there's some concerns which were raised about replacing human with the machine, leading to loss of jobs and some other issues which may be there. So whether the translational potential exists for a pan-India translation, or does it come to only a selective translation? Your last word on Dr. Rajesh. Well, what do you see in a decade from now? What proportion of our sub-centers in the country would go digital?
So to be, I would say in the immediate future, what we also heard is that the NDHM is coming up with version 2 now. East and Jeepney is also coming up with a new version of it. So I think we will have to, over the next shorter term period, we will have to gradually see how these things are accepted by the people. What is the potential for it to be effective, and are they really efficient, and can we integrate it? Because if you remember, just about, I think a month back, there was a huge meeting of the National Digital Health Mission where the secretary and everybody said that what they are looking into NDHM is going to be groundbreaking and completely different from what we have in other countries. It's going to be open, and people are going to, it's going to attract all the people to get their devices integrated. So a lot of quite ambitious, and if it happens, probably then, if we have all these enabling factors, policies and resources available, then I don't see any challenge that our primary health centers will become digitalized and they start using digital solutions in a big way. Because this is, wish only place to create proof of concept. So this is something that we are trying, and it's not been an easy journey with no teleconsultation. like what Ajit asked a very interesting question. Now, we are at one time we created our own portal, but simultaneously we are supporting the government in rolling out e-Sanjeevani. So that experience also is helping us to understand. But when we started, there was nothing of that devices. Only few private sector providers were there, which were there. Now, of course, we have. So it's been an interesting journey, and I do see a big potential for it to change the way that we are, we look into the health and wellness of the people.
Thank you so much, Dr. Khanna. It has really been an eye-opening presentation, and as you can see, there's a lot of interesting questions and lots of areas where people delved into, a lot of finer aspects also, which I'm sure as we journey into this fascinating field, we will learn more about this topic. And the translational potential in a country like India with remoteness, with lack of accessibility and lack of availability of trained manpower, I think is going to serve as one of the most important panaceas for all maladies, I would say, in the times to come. But that does not mean that it will offset the human resources or the doctors or the pharmacists or the nursing staffs with good skills, because that human touch is always paramount to the well-being and the improved clinical outcomes of all patients. So I would now request Dr. Praveen Venkatgiri, Secretary NQCN, to propose a vote of thanks. Over to you, Praveen, and say a few words. Yeah. So can we, Praveen, can you hear us? Okay, so I think there's some connection issue with Praveen. Okay,
yes, sorry.
so,
I mean, I could sincerely only thanks for the presentation and the interaction, and a lot of questions are there. So somehow, if we can follow up with those questions and answers, we should be able to share through email. I hope Dr. Khanna is okay with that, because the interest that this has generated is enormous, and we look forward for that. Thank you.
Yes, more than happy. We'll make sure that we reply to them within a day of when you send us the questions.
So thank you so much, and we look forward to connecting again. And we also invite you to a couple of more innovative sessions on the communities of practice. In fact, this month is quite busy for the NQCN communities of practice. We've got a presentation coming up from the Harvard School of Public Health, and then another one coming up from the NHS UK. And then a couple of point of care quality improvement workshops in Armed Forces Medical College, another one in Lady Hardinge Medical College, and another one coming up in Civil Services Institute. These are all physical workshops, by the way. After a hiatus of 2 years, I invite all the members to actively visit the Communities of Practice platform and gain access to such learning resources, as well as interesting sessions like today. And officially and formally, again, I would like to thank Dr. Khanna, Dr. Anupa, Satyaban, and all the team from the Wish Foundation, and of course the NQCN office for facilitating a wonderful communities of practice session like always.